So good morning, everyone. Welcome to Grand Rounds. It's my privilege to introduce Dr. Ahmad AbuSalah for Grand Rounds this morning. As a little bit of context, as many of you know, we've been working in the department to build our informatics expertise and capacity, and that's been thanks to the vision and leadership of the department leadership here. So Dr. Colleen, Dr. Firk, Dr. Khalifa, and those activities have been included. We're hiring additional folks into informatics. We're investing in operational, translational, and sort of commercial applications for development. And we've also recently started a sort of virtual division of computational pathology that's led by Nathan Pankratz. And so you'll be seeing lots of activity around informatics in 2019, and there'll be lots of opportunities to be involved there and lots of exciting work coming out of those initiatives. But we don't do that activity in isolation within the department, and we're very lucky to have partners at the Institute for Health Informatics, which provides broad biomedical informatics support to the entire university. And as many of you know, that data is really fundamental to both the operational practice of laboratory medicine and pathology, but it's also so crucially important for secondary uses in health research. And while generating clinical data is a fairly straightforward process, there's a whole discipline of sciences in how that data is extracted, transformed, modeled, understood, and then served in a research capacity. And that's a very heavy lift, and we're very lucky that we don't have to do that lift alone. We're very fortunate to have Dr. AbuSalah and his team to lead those efforts broadly for the university community. And one of the most common questions that I've been asked since starting last year is, I have a research question, I need clinical data to answer my research question. Where does that data live? How do I get it? How do I understand it? And so, I've been trying to spread the message of Ahmad and his team. And so that's why I'm so thankful that he could be here this morning to share that directly with the department and the ways that we can partner with them. So Dr. AbuSalah is an accomplished informaticist. He's a core faculty member at the Institute for Health Informatics here at the University of Minnesota. His principal role, he serves as the Director of Clinical Informatics at the CTSI-BMIP Informatics program, and as well as for the Masonic Cancer Center. In this role, he leads the informatics consultation services, which provide the full suite of informatics consultations to both researchers and PIs. He has master's degrees in computer science from both Purdue University and the University of Illinois, and he completed his PhD in biomedical informatics here at the University of Minnesota. And as is so often the case with folks of his great talent, is we have to compete against commercial enterprises, industry for talent. And so Ahmad served a tour of duty with the United Health Group, and we were very fortunate to be able to have him recruited back to the University of Minnesota, and we benefit from his expertise in sort of both of the academic disciplines and the commercially focused domains. Dr. AbuSalah's areas of interest include large-scale data management, informatics, infrastructure models, value-based models for the support of patient safety, quality of care, and cost reduction. And this morning, he's going to be talking to us about biomedical informatics infrastructure for the support of clinical and translational research and the mechanisms for unlocking clinical data in our research. So please join me in welcoming Dr. AbuSalah.
Thanks, Joe, for the invitation, and thanks, Bharat and Andy Nelson. I don't see Andy here, but thanks, everyone. I'm really glad to be here today in this grand round. And as Joe mentioned, my name is Ahmad. I'm in the informatics team. Oh, Andy, just mention your name. Good morning. Okay. So as Andy mentioned, basically we run like the informatics program under the CTSI and with strong collaboration with the informatics affiliated faculties and Institute for Healthcare Informatics. We grow basically based on collaborations. We receive requests from the departments. We receive these departments' requests. We get more work with the consultants. They tell us, I would like to see my data in this way or that way. This is how we actually grow as an informatics infrastructure. And this talk basically today, I will cover basically the CTSI-BMIP, Best Practices Informatics Core, which provides dedicated resources to multiple departments based on our agreements with the departments, like CTSI-BMIP. The resources, part of the resources are dedicated to Cancer Center. That's the Cancer Informatics shared resources. Some of you maybe worked with Vidya and her team. These are all part of the CTSI Informatics Core. We have resources who are dedicated to School of Dentistry to provide dental informatics services. Resources who are dedicated to surgery, Department of Surgery, to provide surgery informatics resources, and they have surgery informatics core. So basically, we look at the CTSI-BMIP as the hub to provide these dedicated resources who can learn your data, work with your data quality issues, work with your research problems to be more efficient. Then number two, we're going to cover the infrastructure. What is the current infrastructure, the secure and compliant infrastructure? What are the data sources? How can you get actually access to the rich data environment and informatics services? And then like mention some of the recent informatics collaborations that we established with various departments. So as mentioned, basically CTSI-BMIP is the best practices informatics core. The goal of it basically is accomplished by CTSI. It's like award. It's funded by CTSA award, plus the CSG award, etc. And it has basically the main goal is to provide state-of-the-art centralized clinical informatics services to the AHC community in terms of and collaboration science opportunities to support research, operations, and quality of care improvement. So we have some requests from PIs and research staff who are project specific. I have a research question. I submitted my IRB, and hopefully actually we receive the request before you send it to the IRB. So we can refine it and give you the data for or the text that you need to before you send it to the IRB in terms of data security and data compliance. So that's the research. And we have operations. We have leadership from programs. They will tell us, I would like to have automated reports, like monthly reports that we send to the Cancer Center about clinical trials, which are opens, how many patients have been recruited, how can you compare encounters data to clinical trial data, which is now like a hot topic in Cancer Center, and we're trying to basically address these data quality issues. And quality of care improvement, like Department of Anesthesiology, who wants to understand, only show me like my high-risk patients, and how can we basically review it in a timely fashion. So we have now in the clinical informatics program, we have 20 plus data analysts and system engineers and developers. Plus we have 16 plus informatics faculties who are affiliated with this service. So when we receive a request from you or from a researcher, the first thing we do is basically you will basically sit with a data analyst. Sometimes you have your team and you just, what you need basically just give me data. So the data analyst will fulfill that request and process it for you and send you the data. Sometimes it's like, I have my research question, I'm looking for a collaborator who can help me with refining my research questions, build a team around this, so you can be the PI and we can be collaborators with you to submit grants and prepare grants and manuscripts. So, and that's all basically in the phase 1 consultation process, which I will cover later on. So we're actually, the clinical informatics program is part of the overall CTSI Biomedical Informatics program led by Konstantin Aliferas. So I manage here just the clinical informatics services. Although the infrastructure that I have in my team, basically we supports bioinformatics, which is led by Dr. Steve Shin, then also the cancer informatics for Jinhua Wang, Ru Zhang for natural language processing, Josh Furman is managing the clinical trial management system. I'm pretty sure if we have a clinical trial, then you know this name. And Steve Johnson, which is like our newly added division here, is managing the informatics dissemination. And his goal basically to establish collaboration with external entities and take our tools that we built in-house, developed in-house and validated and published, and push it to other institutes, whether CTSA or industry, for research or operations or quality care improvement. This is like a lot of text, but focus maybe in this column. So the main service that we provide here, it's number one, data access. data access to clinical, genomics, dental data, and we'll have a slide about what data exactly we have. But this is actually number one, is actually access to rich data environment. We can provide you in terms of access, you and your team, and we have a data governance rules that says who should have access to what, is it identified, de-identified data, etc. And so access to data environment, then the clinical data extraction. When we provide you access, actually we put it in the secure environment. It's locked, it's controlled environment. You cannot take the data out of it until you have the right approvals from various legal department, which we have procedures and policies already established. Then data identification, we have also like our validated de-identification tools that have been approved by the IRB, HIPCO program in the IRB. So we can extract the data fully de-identified and send it out or share it with you and your team. Patient recruitment, clinical trial patient recruitment, we have a slide about that. And reports, data repository, and registries. When you talk about actually domain-specific registries, I have a couple of projects here like in this slide to share with you. Domain-specific registries are basically led by a PI or a faculty from a domain-specific department. So we can say, like, let's say, Department of Urology. One of the projects I will show here is Dr. Chris Waite from the Department of Urology. He built a kidney cancer registry. So we brought the data in, we massage it, we enrich it, etc. But then he will add his departmental, basically, data quality rules. That, okay, you have this data, you brought it to me, you enriched it, you run all this stuff, but I would like to see it in this way. So we run it all, and we do everything automated, from whether it's from coming from RedCap or coming from Encore or coming from Epic, all this fully integrated, automated. Like, so you have I think 1 week delay in his case, and he can actually reduce it to a couple of days delay. So, and UMP data. And that actually infrastructure is already built. So when we build another domain-specific registry, we just like customize the data quality rules and cohort identification, inclusion, exclusion criteria. Then informatics infrastructure. So informatics infrastructure, we have entities who want, collaborators who want to bring data from outside entities to the university. We work with them and we bring the data in. And one of them is basically will be the 10,000 family project. So we have the infrastructure, it's already PHI compliant. We have the tools to bring the data in, various technologies to bring the data in, and that's already established and approved by all entities. Data analysis tools can be in a tier 1 analysis, what we say like dashboards. We massage your data, we enrich it, you look at the data, you review it, and you say, okay, put it to me in a dashboard so I can access it anytime I want, and look, I have basically a data summary of all my patients. What are the main diagnoses, what are the main procedures, how many patients have been seen by each doctor, etc. How many clinical trials, how many patients recruited per trial. All of this can be done in dashboards or automated report, sent even via email if no PHI data out there. Tier 2 analytics was basically the advanced data analytics and machine learning. So we're talking about data being extracted, and then you have the biostat service coming from BDAC or coming from basically, or maybe you have your own biostatistics, or you want basically advanced data analytics, machine learning, causal modeling, the graph data mining, etc. All these techniques can be used and help you then with the publication and research. And that will be with the informatics faculties. Application development, we have developers in our team, and basically we work closely with the ASCIS. Actually, everything here is closely worked with ASCIS folks. So we build actually system designs, mobile applications, user interface, etc. And then, as I mentioned, manuscript and proposal preparation and informatics resources. Informatics resources is kind of, we look at ourselves as kind of a hub. So we hire resources, we train them, we give them access to the data, and then they are dedicated to your department for your projects. The academic healthcare secure, academic health center secure data environments. The ASC SDE now has been, I think, running for since 2000, about 5 or 6 years. And as I mentioned, basically it grows based on requests from researchers. It grows based on guidelines. So if we know there's a security guideline that we need to meet, then we right away implement it. Like recently from the University of Minnesota, we get the 2-factor authentication requirement. That actually was a huge impact to our department, to our infrastructure. But now we have upgraded everything to meet that requirement. So security guidelines we have to meet, feedback from users who say, I would like to include this new data source. I would like your data to look like this, not like that, etc. So all this one. And then the third one is best practices. So we compare our infrastructure to other institutes who are in strong collaborations in various committees with other institutes, talking about we have meetings with Harvard, with MIT, with Columbia University, with the last couple of weeks, University of Illinois, etc. And we compare infrastructure, basically get what works with them, what works with us, and share lessons. And this is the quick metrics of how many patients we have in the environment since metrics from June 2018. We have about 3 million patient records in the CDR and the clinical data repository. We have dental records about 450,000. Currently active users 540, and we say active user that they have logged in the environment in the last 30 days, 45 days. So it doesn't mean that all the users in the environment, just like those really who accessed in the last 45 days. Sometimes we have researchers which we extract the data to them, deliver it to them, and they don't see it for 3-4 months until his deadline is closed, and then suddenly he becomes so active. I'm that one. I do that. So we have more than 700 users with access to some data tools, whether it's I2B2, Trinetics, or CTC Act, and we'll cover that. Number of consultations we received in the first 6 months of this year, about 400 consultations. This can be research, operations, or quality of care improvement for data extractions, building systems, or help with grants and preparation and proposal. Number of dashboards, 30 dashboards, and support the clinical trials, almost 1,200, more than 1,200 clinical trials. So when you say the clinical trials, we get a copy of all OnCore data into the secure environment in the backend. So we work closely with Josh Furman's team, CTMS. They build the clinical trial protocol, plan, etc. But in the back end, we get all this data into our environment to be able to generate reports on how many patients basically get recruited, what are the issues with the data with the clinical trial, notifications, etc. This is all being done in the back end with support of our team. Domain-specific registries, 14 registries. The last one that, as I mentioned, was the kidney cancer registry we built for Department of Radiology. There's one that we built for Department of course, the BMT one, the Department of Anesthesiology, Surgery, etc. But I think now the one that we cover today is also the new one that gets approved by Cancer Center, is to build CPR, which is Cancer Prevalence Registry, that has all the common data elements that impacts all types of cancers, and then from that build domain-specific registries based on cancer type. This is the very quick overview of the infrastructure. So these are the data sources we currently have data from. Actually, we have more, but this is what we fit the diagram. But and then once we actually get the data, we put it in our landing zone, group it per type, and then run it by our clinical admin console tool, which was developed in-house. And this tool basically allow us to, most of these modules are embedded into the clinical admin console, and it's now validated and in terms of publication, and we're going to also disseminate this tool to other sites. It has terminology management, so you have your code, you have ICD-9, you have ICD-10, RxNorm, NDC. This is already embedded into the tool and can do all this job in automated fashion. Then the code set mappings, you have the patient matching algorithms. We do the patient matching, we have multiple patient matching algorithms, but the rule here is to have 2 data elements for patient matching, at minimum 2 pieces of information. Usually it's the last name and date of birth, but if we don't have the last name and date of birth, we need to have other 2 data elements for patient matching. Then we have the NLP indexing. NLP indexing, we have a tool called NLP peer, sorry. NLP peer, that actually will read the clinical notes, parse it, and make it available for researchers. That won't be actually accessible for all clinical notes. You should identify your inclusion-exclusion criteria, and then we identify the set of clinical notes and connect it to the NLP peer. There's no 100% accurate NLP peer tool in the world, so if you may achieve 80 or 85% accuracy, that's good. That's why most of the time you find that clinicians, they hire some staff to build this REDCap form in the site so they can review it and be sure that everything is accurate and enter the accurate information into the system.
question.
Yes, please.
The Optum part there on the left, do we have a site license to Optum?
Can I hold the question
Sure,
first?
yeah.
Yes, but actually the short answer is no. But let me, I will describe it more like in a second. Yes. The HL7 messaging, that's actually for bringing data in, and then common data model mapping. Common data model mapping, we have like the CoreNet, for example, is one of them. If you want to collaborate with other sites, especially in data sharing networks, they will ask you, do you have a common data model? We have actually multiple common data models. The most common is the PCoreNet CDM, common data model, so others can query us and we can query them just for feasibility analysis. So they cannot look at individual records, they can look at the counts. And we have Shrine, so basically if Shrine network, and we have a part of TrianText. Maybe this is I will cover this like in a second. So then once actually you extract the data for multiple reasons for data, we put it actually for you in the data shelter, and that's like maybe, I know sometimes it's inconvenient for researchers to put it in the data shelter, but that's actually our agreement with Fairview is to have it inside a sandbox. It's a controlled environment. It cannot be like really shared outside the environment without appropriate approvals. So if it is fully de-identified data, we can take it out of the data shelter and push it to you. If it is a limited data set, we'll need to have a data use agreement with you and then run it by a data governance committee from Fairview. And there's some exceptions basically here. There are policies, but there's some exceptions. What can be taken out of this environment and not. Also, we shared, as I mentioned, with some data sharing networks. Or if it is not Fairview data, we can push it out of the environment using some PHI compliant tools. Like some AACIS folders are PHI compliant. Box is a PHI compliant tool as well. And in the bottom here, we have this data security layer. And this is a security layer. We work closely with the Center of Excellence, HIPAA Data Center of Excellence from AACIS, and the Office of Compliance and HIPAA, like Rick Wagner and Lori Catola from their office. They have regular auditing for our environment, procedures, how we extract data, how we deliver it. Do we have all these technical requirements that meets NIST and IST and HIPAA and etc. So, and this is security not just internal, it's also by Fairview and all our data providers. Then data governance, we build our procedures and policies, and we review it. We just actually sent, we usually toward December, we send like an updated version of procedures to our reviewers and tell them, okay, review our latest, based on our experience with the researchers. These are things that we recommend to be included in the next round of data governance and procedures, data governance and policies and procedures. These are the data that's available inside the environment. As I mentioned, the data from Fairview. You have EMR data, genomics data, which will have also a slide about it. It's like the most recently added data. Then CVS data, Optima, PaceArt, Accelera, Echo, and UMP Flowcast data. From Masonic Cancer Center, we have BMT data, LIMS data, FreezerWorks, the Kidney Cancer Registry, and other domain-specific registries. OnCore data is like a daily feed from OnCore data. Dental records now we established is fully integrated. All of this actually is fully integrated inside the environment, which means by fully integrated, you have you can look at the dental record, you can look at genomics data, you can look at the clinical data. It's all being linked inside the clinical data repository. Then the master death index from Department of Health, and UMLS data and ad hoc request. Like we have a researcher who wants like AHRQ data, NIST data, or trauma data from Department of Surgery. Dr. Chris Tinglini, he deals with the trauma, National Trauma Data Bank. So we got that data for him and prepare it and make it available for his team. CMS data, some researchers, they get CMS data from ResDAC. So we get, but to host the data, you need data security plan. So we help you with data security plan, that we have a secure, compliant environment and bring the data into that environment for your team.
Quick question.
Please.
On that slide, the one thing that I don't necessarily see is pharmacy data. Is there an integration of pharmacy data as well, or is that only being pulled from the EMR?
From the EMR, yes. So by pharmacy data, you're talking about like the community pharmacy, right?
Yeah,
community,
whether, whether they get chemo infusion, whether like
yes.
Ondansetron, whether, so if we're trying to go into the EMR and we're trying to query,
yes.
What chemo was given, what supportive care was given, et cetera,
yeah.
that's all coming directly from the EMR rather than from
yes.
separate discrete pharmacy records, which
from the pharma system. Yeah, which is actually, now this is actually what you request is covered under the agreement. So you can bring it in. If that's actually a request from you, please submit it. We can bring it in. So that's covered by the agreement. And we had actually a couple of meetings with them. I forgot what's her name of last year, but we met with them and it's already covered. We get the legal approval.
Yeah, yeah, for the ovarian cancer project.
Yes.
I was wondering, is the information about Biomed and the samples they have, each samples, is that under the LIMS or where is that?
No, the Bionet is actually different than the LIMS. Bionet is actually now, look, it's a different team. The director is called Cancer. Exactly. So, what we have done basically, yeah, we built for them the biospecimen BSI tool, biospecimen interface thing, and we built it now. We are on the stage of waiting for them to bring the data in. I think most of it is in paperwork. Now it's paper, and they just need to type stuff in. They have the tissues, they have the bank, but the data ultimately will be here. And we have actually in March, we have another meeting with their team to be sure that they have actually entered and completed everything into the environment. So the infrastructure is there. Once they enter the data, it's going to be fully integrated. So we have built infrastructure, we have the software, we have procedures actually how to extract the data once it's here, but we just need them to complete the paperwork, basically extracting all the data from papers.
So do you know when that will happen?
I hope it's in March. Our next meeting, we just met actually with them a couple of weeks ago. It was a data governance committee, and they presented, and the deadline that they gave us is March. So I hope at that time we will have.
So I have two questions.
Please.
You mentioned you have a master death index.
Yes.
Is there plans to expand it beyond the Department of Health to the national death index?
We don't have an issue with that, yes. If that's actually a request and you feel like there's an issue with this one, sure. As I mentioned, basically, Bharat here, we are driven by your request. If there's an issue with this one, which by the way, my experience is there's no this index that's complete. You can actually find some information this index that's which actually we found this actually many times, that information that this index is contradicts sometimes with the information from the EMR record. You'll have in the EMR record that will tell you the patient is alive, but this index tells like he's dead. So and this index actually has justification why he's dead. So and we try actually to use this one as a source of truth for us, but still it's I won't call it complete 100%.
And the second question
Yeah.
is for the spatial data.
Yes,
Are you working with the Minnesota Population Center?
exactly. That's where they're coming from. It's like the tool that they use is ArcGIS. I don't mention it here, but we use ArcGIS from Population Center. Yes. Any questions? Okay. The recently added data source, and this is actually managed by the Bioinformatics group, Steve Shen and Jinhua Wang, the genomics guys. I think with collaboration with everyone from here, like with Joe, Andy, and Bharat, and others. So if I have a question about genes, I'm going to refer to you. So Cancer Genomics, we get actually Cancer Genomics data. We get Cancer Genomics data from actually Fairview Labs. Typically, this is like 21 gene panel, and the latest count that we just got before yesterday, we have almost like 3,600 tests loaded, starting in 2015, and we receive VCF, BAM, and FASTQ files, and this is actually now fully linked and integrated with the CDR. Foundation Medicine data, it's different platforms, have more tests. The recent count that we just did is 316 tests loaded starting 2005. And so far we have been seeing like PDF and XML files reports. So we have to extract this, like parse the XML and PDF and load it into the environment. And this should be like now, fully integrated. I think we are now in testing phase to be sure that actually everything is working. And Jinhua is working with your department and Tim Meyer to be sure that, yes, it's fully integrated. Actually, once we are done with this, we're going to go to Keras and work on that.
Are we almost real time with the Foundation Medicine data yet?
No.
Not quite.
No.
Okay. Yeah, just from
No,
the tumor board, if we actually keep any momentum going with that, that will be important that we actually start to get real time access to the XML report in advance.
So real-time access for the feed. You're talking about the feed.
Usually the patients that are sent to tumor board, it's usually probably I would say a month or 2 months after the Foundation report comes back. Anywhere probably between 2 weeks and 8 weeks from the time the Foundation report comes back.
Yeah. So you're talking about not real-time access by researcher. You want the real-time access feed from Foundation. Got it. Germline data, we get the germline data, but now actually it's like we put it like in isolated server. No one has access to it, even including our team. Oh, here you go. So I think like we need like some filtering of data to be sure that it's only fair view data. So that's currently is unavailable to researchers. Metadata, we can actually now we get the metadata as well from the genomics data sources, like especially for cancer genomics data. We get like a collected date, received date, exclusion. But the most important is that we now can link clinical data, genomics data to the order to the COPATH report. So that's all fully integrated. COPATH reports is already there in the environment. Has been it's a free text format, and we currently utilize like NLP tools or build our own programs to extract data out of the free text. And working with the Department of Pathology, with Joe others, once we have structured data available, we will bring it in the environment. Data sharing networks, I'm going back to address the Optum Labs question. Data sharing networks, we are part actually of Trinetics, CTSA Act, and March. And that basically gives us the ability to query other sites, get counts from them, and before you start collaborating with these sites. I can provide actually a list of all the sites provided, funded by, or basically available through Trinetics, through the CTSA Act and March. The goal here is we can submit a query to them, or we have the tool to query them. It depends. Like Trinetics, we have the ability to query them. For March, we send a query to the network, and they send us back within a week all the counts if that meets your inclusion and exclusion criteria. The goal here is like to basically be sure like that we have patient recruitment and enhance like basically patient recruitment, which is like an issue now for all clinical trialists, and feasibility analysis purpose, and attract clinical trials. Like Trinetics, one of the major, I would say, advantages of using Trinetics is that pharma industry, most of the pharma industry is connected to Trinetics. They can look at our data in terms of counts and feasibility analysis. They send us almost like in monthly, send us multiple opportunities for collaboration. They have a clinical trials, it's funded, they're just looking and they queried our data. They know that we have patients, enough counts that actually for them interesting for their clinical trial. So they basically reach out to us saying, do you have a collaborator on this? And what we do, basically we take this and send it to the research directors or managers from multiple departments and tell them, do you have a collaborator? This is funded a clinical trial, and we receive a couple of opportunities each month. And I think like since the beginning of this year, we get like about 40 some trials, and the established ones are 15. Biomedical established that we found a collaborator who is interested of being part of that clinical trial. Sometimes the researchers, they will push back because of a competing clinical trial here at the university, or just no bandwidth. Now, Optum Labs data, we have access to feasibility analysis access. So we can actually query the data and tell you, do you actually, is there like enough data in Optum Labs data warehouse to satisfy your research question or not? That's before you purchase the data. Once actually you find, yes, it is actually interesting, I would like to proceed with Optum Labs, then there will be actually, it's expensive. And that cost will go to Optum. And I don't know, fortunately, I was part of Optum when we established the agreement. But now actually I know that Constantine and Jacob Toller, etc., they may basically take this to the next level and review the agreement with Optum Labs. Today it's very expensive. For example, Department of Surgery, we'll work with them. They have an agreement with Optum Labs. I don't know how much they pay, maybe 60 or 90K, just to support a couple of projects. Other departments each department basically is paying almost the same amount to get access to Optum Labs data. So we're trying actually to have we are preparing actually some documents now, and hopefully we'll go to Optum Labs and review this agreement to make it kind of enterprise license, which we're trying to address now with IBM. This is in progress. We had a meeting last week with Legals, Office of Compliance, ACIS, OGC here, Informatics, Joel Farley from the Department of Pharmacy, and Carson School of Management, Pinar. We want to bring IBM market scan data to the university. We get an agreement, but it's like now with our legal review, and that should be actually an enterprise license for 3 years. That will be available to AHC faculties plus Carson School of Management, and that will be starting from the data from 2012 to 2017. So if we get that one, this will be actually much, I would say, better than getting the Optum labs in terms of financially. It's going to be IBM will be better. And it's all claims data. The IBM data doesn't have actually EMR data. Optum labs, they have 150 million lives, all the claims data, but also 20% of them have EMR data. Optum labs is fully de-identified data, but you can still track the patient across records. Here it's a limited data set. It's fully it's de-identified in terms of patient record, but they still have dates, the actual dates. So you can tell when was the procedure done, when was the claim submitted, the lab test done, etc. So and that's why we call it limited data set. And to get access to it, we will need some data use agreement with the researcher. How to get basically query the data in our environment? We have two tools like I2B2 and Trinetics. These are simple feasibility analysis tool. Not all data are connected to I2B2 and Trinetics. Now, if what we have done basically in the past is we work with the department to tell us how I2B2 should be enhanced. We have departments who initially came to us, I2B2 just generates wrong numbers. And that's actually the requirement we get from you. We say, like, okay, let's run some tests. What are the issue? How can we enhance it? So we are like, for example, Cancer Center now, we are trying to build a task committee from multiple domain-specific cancer types and say, okay, how do you want actually to look at I2B2? What kind of queries do you usually run, your team run? Trinetics, I would say it's a nicer interface, and currently has actually, I see like actually more users using Trinetics than I2B2, just because the interface is really nice here. Of course, detailed and accurate analysis needs to be done by an analyst. This can just give you like a quick, rough count. How many patients do I have under this ICD codes? How many patients I have like for this like age range, etc. But once you go into the detailed inclusion/exclusion criteria, this should be done by an analyst. Submit the request to us, and we can create the counts for you. This is the NLP peer tool. The NLP peer, basically, it's like we receive the request from you. I would like to look at the clinical notes, surgery notes, etc., or co-path reports. We extract all these co-path reports, connect to the NLP peer. We give you access to query the co-path reports just for your specific project. And this tool now has been actually, I think, adopted by maybe 5 or 6 other sites as well. Custom dashboards that we build usually for operations purpose. And this is actually real time. You have the link, you can access the link anytime and look at the real time data. Data governance policies and procedures. This is actually the latest policy that we just sent out. So our procedures, when we send actually out a procedure, we review it by IRB, Office of General Counsel, Office of Compliance, University, actually OIT, Office of Information Technology, Fairview for Epic Data, and of course other systems from Fairview, and information security policies that covers the University of Minnesota. So that's why actually when you send us a request for data, we know exactly what approvals you would need. We know that if you are like a researcher and you want for research request, we can tell you it's an IRB. If you have an active IRB, we can send the data to you. If you want to look at the data, you don't have an IRB, you just want to look at the data, we have a attestation form. It's called PREP for research, and that's approved by the university. You can just sign it, and we can give you access to identified data to look at it, to be sure that, yes, the data matches what I want before you even proceed with your research. The common data extractions we have, usually we have researchers who ask us, you want to build me a database, a registry. I want all this data coming from all these sites to come directly into my database so I can have timely access, or I wanted to have my analyst look at this data at any time. Files, they may ask us for SAS file, Excel file, SPSS file to be generated, or of course data summaries and data visualization dashboards. Dashboards are accessible outside the secure environment, just simply because usually it has aggregated data and fully de-identified. Patient recruitment requests for clinical trials. If you have a clinical trial, you want to recruit patients, we have this detailed process that actually approved by Fairview and the University of Minnesota. So we can ask you to run it by, number one, by I2B2 and Trinetics. Do you have enough data? If the I2B2 and Trinetics doesn't answer you, then send us a request. We create counts for you, and then from that you will know that yes, you have enough patients for me, and you proceed with the IRB submission. From the IRB submission, then you need to notify FRA, which is the Fairview Research Administration, GIRCOR desk team, and we can help you with that, and inform us that you submitted an IRB. And two of our analysts are IRB and cellular reviewers. So every time you request data from ASCIE or the secure environment for EPIC data, this request automatically comes to us to review it and basically provide technical review to the IRB submission. Number 4, basically the PI will write letters and share with the FRA, Fairview Research Administration. And from our team, we extract the data, identifiers data, and send it to Fairview. We cannot share the data with the PI. That's like the Fairview guidelines. And then work with the University of Minnesota printing office and mailing service. They will prepare the letters and send out to patients. Application development, some web pages or mobile app, or for purpose of time trying to. This is a recently added tool, the cBioPortal for cancer informatics, or Cancer Genomics for the genomics data analytics. cBioPortal is now basically managed by Jinhua Wang's team, the Cancer Bioinformatics director, and it's now available. This is like, I think, best practice. We installed a local copy of cBioPortal. It's now available through the cbioportal.cancer.umn.edu, and you can upload data, genomics data. You can retrieve data. You can do correlation statistics between RNA expressions and methylation, and oncoprint and correlations between clinical information along with the genomics data can be observed. So all these features are available now through the cBioPortal, and we started seeing this has actually been available since June. We have seen 2 or 3 projects that have LPIs have used this tool. So we're trying now to share it with the community that it's available and running. Some collaborations, the recent collaborations that we established at the departmental level, and some of them are a PI collaboration. For example, surgery collaboration. We have this the CIRC committee, which is serves the Department of Surgery needs for informatics. So this is at the departmental level. It has started about a year and a half. We currently have 8 research projects at various stages. Some of them are starting from feasibility analysis. Some of them are now preparing the grant proposal. Initially, actually, when we started this, I think Department of Surgery, they already purchased the license for labs data. And then they come to us, okay, what to deal with this, what to do with it. So, but actually we found out that most of these projects, or say 50% of them, can be addressed using EPIC data in Fairview. So some of the projects are using EPIC, some of them are using labs, some are using trauma data, and other sources. We created for them a process in which they basically manage the priorities, because they have 2 FTEs informatics resources. One of them is data abstractor, one of them is the data advanced data analytics or scientific programmer. So we prepared this committee, CIRC research committee, which is actually managed by Department of Surgery faculties and one informaticist from our end. And they decide how do they want to use these 2 FTEs. Initially, we actually got 15 projects to be executed within a year, and all of them we wanted grants, so it wasn't really possible to do this. So we formed this committee. They decide, they assign priorities to their projects, and they tell us, okay, this needs informatics support. Then we start with the cycle here to prepare the data, extract it, analyze it, and then work with them on publications and research. And even here we put how resources can be utilized. If you're using labs data, you can use our resources, but if you're using EPIC data or other data, we can extract it to you, but if you have a data analyst, they can also manage the data or analyze it instead of waiting for other researchers. This is one of the recent, I think, publications from Department of Surgery. They basically, the challenge here was it was unclear for them the role of bariatric surgery plays after the breast cancer diagnosis. And this is Amblaze, Cramidin, and from our end, George Simon, Mehmet, and even CC was, I think, provided a little bit support to this application. And what we have done, basically, we used labs data. We did retrospective study analysis. Multivariant Cox proportional hazards model were developed, multiple of them actually, and validated, heavily validated, and then published. And they found basically that actually BS is associated with the reduction of breast cancer events compared to non-surgical care. This is another project which I mentioned basically for Dr. Chris Wade. I'm trying here just to mention the most recent projects that we have done, building a registry, kidney cancer registry. So he has data. Initially, we worked with him to design this architecture. It's PHI compliant, secure, everything is approved. It has data from surgery, social history, labs, comorbidities, clinical notes, pathology reports, REDCap data, and medications data. The data from REDCap and EPIC and UMLS, all of it are actually in the back end fully integrated. So they don't need really to download REDCap data and extract it and send it and share it with us. We just build the pipeline, so every time actually there's the REDCap, new REDCap data, it's come directly to us, and we utilize the infrastructure, these components from the existing infrastructure to massage the data and enrich it. The two boxes here in yellow, these are the customized components. So when we build another registry, we just need to get from the PI, okay, how do you want to see the data quality rules, what should be filtered out, if this value is null, then maybe we should default it to something, etc. And of course the inclusion exclusion criteria. And we make this registry available to his team with all the tools in the data shelter, SAS, R, Excel, SPSS as well, and data identification tools available, and data set generation. There's a tool that you can extract the data using like any format that you want. You want like even if you want like a SAS file, you can use that tool to extract the data file in SAS format for your researchers and staff, etc. Based on that kidney cancer registry, now Sonic Cancer Center, he wants to build a cancer prevalence registry, and the main goal actually of this one is to be able to efficiently run the clinical trial feasibility analysis. What we found actually when we joined the Cancer Center is that like, there's a mismatch between encounters, between ENCORE data, REDCap data. There's like, numbers are, it depends whom you ask. You can get a different answer. So we propose this like, architecture based on the kidney cancer registry, and this will have all these sources, and which is like you'll find actually inconsistent numbers if you get, for example, Fairview. If you go to Fairview tumor registry and go to EPIC or go to ACCR, it's a mess. So we create like we look at this data. This is what we presented to Cancer Center. Told them, look at this data. This is coming from the data sources to us. So what we have done is we propose is we will get all this data. There will be a summary report that says, here's what, if you read VIA Oncology, here's what it says. If you read EPIC data, here's what it says. Fairview tumor registry, here's what it says. And in the registry, at the end, we will say, we're going to apply some priority logic that says, if data from EPIC contradicts with data from ENCORE, then use ENCORE data for discount. So try to build a priority logic here that says who should have access to it. Cancer Bioinformatics collaborations. This is Jinhua's team and Aaron and Alpe and the research scientist. They're focused mainly like now on the cancer genomics data analysis, and this is one of their most recent studies. I think they were part of it, Jinhua, and I will leave this to the bioinformatics team to present. I won't feel like an expert here. How can you get access to the data? You can just email us at epic@umn.edu or use the consultation report at zumn.edu EPIC. We will have consultation process, 3-phase consultation process. Initial consultation and scope feasibility, we work with the PI. We address basically what exactly your scope of your research. Do we have data that can address your research? Can we actually do it or not, basically? In phase 2, we could do a detailed planning and work with you in the execution phase. And the part that you pay for is just the execution phase of this. Now, if there's a collaboration on grants or papers, that's not we don't charge for that. So that's why when you work with us, the first question would be, okay, what is this for? Can we be collaborator with you like on this paper or grant? That's okay, you don't need to pay for that. Services, now for the 150 hours, that's actually default, but you need to connect with us because most of the departments, they have support through either their departments or through their like Cancer Center. Cancer Center rates is $9 per hour, and that usually can be funded either through CERTI or CTSI, etc. So just check with us before you, at the beginning, basically at the phase 1, or maybe phase 2, a detailed planning once we talk about budgets. And in 50 minutes. Thank you so much.
Thank you, Ahmad. Questions? We have some time for questions. Yes.
was wondering how far back does your information go? So if we have tissues from 1996 when Biomed started, do you have patient information on them so we can get information?
We start actually in the EPIC data that we received, first one from 2000, I think 10 or 11. 11, yes.
So I'll just add on to that because I think it varies a little bit by the data source that you're interested in. So most folks are interested in pairing clinical data, and so I think that is sort of the timeline. So we're starting to work through this with IHI and BioNet because there is the COPATH system goes back beyond that.
Yeah.
So we have COPATH data dating back to, I don't know, 2000, somewhere 2003, 2005, 2002. Okay, thank you. That was before my time. But yeah, so it goes back quite a ways. And that data may not be represented within, say, the clinical record in EPIC. And so we're trying to figure out ways that we could go back in the LIS and be able to pair pathology report data to those samples dating back at least to the early 2000s, even if we aren't able to serve clinical data alongside that.
Here's the real world example. So for the breast cancer translational working group, we have two different cohorts, the DCIS cohort and the research cohort. We completed the 100 patients in the DCIS cohort. We've been working on this team. We've been able to match about 80% of those cases, 75% of the cases with records that exist in the post-2011 EMR data and death records and other things like that. But then for all of the core pathology data, we'll have to recruit the fraction of the whole path and maintain that. And also review what we've done for that time. So it's like half and half. So you can get like outcome data, the outcome from now if you're interested in studying something other than the follow-up.
There also are data from the power path that were re-entered.
Yeah, some of the, so it's,
About 1996 when that.
Yeah. That's a great point. It's a series of waves. Some information is carried forward, not all information. Some is archived off. But one of the one of my commitments to all of you in the department is we won't turn our current system off. We won't turn COPATH off without getting the data that we think we are going to need for the next 20 years to support research as we have archived tissues coming into repositories.
The thing that for you're talking about the historical data or like the just EPIC data, any kind of data? Yeah, for data, reach out to us. Now, in terms even like that email, you can email us, and I think also like Fairview, and I can like just confirm with Fairview, they have access to historical data. It's just like they need to do some work to get it from archival, retrieve it, and send it to us. So if there's like a specific project that will need this data, we can get this from Fairview. This will be actually time consuming since it's not available right now. So
other questions?
I could just comment. I think this is an incredibly valuable resource for people, and I'm so glad you came along to tell us about this. I'm working currently with Ashley on a project. She's just been so easy to work with. Also with the full data. But we have lab data going back for how many years on every patient in therapy?
It really varies per unit. But like I think labs, I would assume 2011. If we start 2011, should be labs data should be 2011. Yes.
If people have projects that they're interested in.
Yeah.
This is the place to go to get that data.
And one of the wonderful things is that, if we extract data from the LIS, we just have the lab view on the world. And I think often for the research questions that we have, the ability to tie this so much more broadly, whether you're talking about to a death index or to other clinical data in the record, to notes data, this is the one-stop shop for helping to answer these questions.
So that's what we're trying to do. And again, think about like the domain-specific registries. If you feel that the EPIC data needs tons of translation or transformation to be ready for your research for the department, we can build that registry that your researchers or your faculties can, yes, we can correlate to this data because we know like how many the issue of data quality issues in EPIC and how much transformation it needs to be.
Yeah, so kind of a self-serving question. Is really working on an natural language, NLP.
Yes.
natural language processing, to be able to identify evidence of recurrence, particularly from like imaging reports and things like that. Because I mean, at least in the cancer world, one of the most difficult things, which requires usually a fellow or a resident going back into the records and carefully quality controlling, is what was the date. You know, so we know from the surgery records and other stuff, it's very easy to automatically pull when we believe we can start the clock.
Yeah.
But as far as ending the clock for relapse-free survival, sometimes that gets a little difficult to extract that from notes. Is that something that we've been looking at?
I would be surprised if he is not, but I can't really tell you 100%. But I would be surprised because that's actually a key question. Yeah.
Very highly valuable.
And it is really a key, like I would say, area in LP, naturally.
Yeah.
So I would be surprised if it's not, but I can
Okay.
I can get you
Yeah,
information.
I can't remember
Yeah.
about that in the past. I'll try and remember to follow up with them.
Yeah.
All right, very good.
Okay.
Well, thank you, Ahmad.
Thank you all. Appreciate it.